All right, Bismillah ar-Rahman ar-Rahim. Welcome with my dear colleagues in our first session for our dear doctors. Today we'll speak about important topic for all of us. It is emergency X-ray. The emergency X-ray is facing every doctor in their work, whatever his specialty, medical officer, internal medicine, surgeon, radiologist, all. So at least we must know the basics of the emergency X-ray for all of us. The X-ray considered the basal radiological examination of many emergencies and medical conditions, but it's not the only radiological examination. It's indicated in many conditions, such like chest disease, and the bone trauma, and the nasopharyngeal adenoma, so the important uses, foreign body ingestion or inhalation, intestinal obstruction, and in the pneumoperitoneum. These considered the main items used for X-ray in the emergency. The first thing to know is the X-ray is an ionizing radiation. Ionizing radiation means it has its own hazardous effect and its own side effects. Of course, the dose of X-ray is much less than the CT, but both are X-ray and both has ionizing radiation and has its hazards. The dose of CT is much more than the X-ray, but both are the same nature. All right. For keys of good evaluation of X-ray film, we have two main items. The first thing is good film quality. The technician must give me a good film to judge the film and to evaluate it. And the second is system for interpretation. I must know there is certain system to interpret my X-ray film to achieve a good result or achieve a diagnosis or at least have acquired a good information from this film. All right. For example, about the chest X-ray. What is the criteria of good chest X-ray? When, for me as a medical officer, to ask the technician, no, this film is a bad quality, this film is a good quality, you must repeat this film, even if the radiologist is not available. The first thing of chest X-ray, the patient must have a full inspiration. In any chest X-ray to be good film, the patient must have deep breath and hold. Not breathing, not expiratory. This is the first step. Second one, the film must view in the top of the lungs at the above, and the lower parts of the diaphragm to be visible on both sides. And on both sides, we must see both cost-phosphoremic angles. The cost-phosphoremic angles must be viewed on both sides. And the spine to be just seen behind it. Let us see, without speaking, such like this. The upper part of the apices, both apex of the lung are seen. The lower part of the lung are viewed. Both cost-phosphoremic angle on both sides are viewed. And we just see the spine behind the heart. Why is the spine? The spine is the indicator if this film is hard or soft. In imaging of any X-ray film, you have something named factors. Factors means the kilovolt and milliampere that the technician is used to take the film. If the kilovolt and milliampere increase, the film will be burned, will be all black. If it's decreased, the film will be soft, will be white like this. So when it just be adjusted very well, we just see the spine behind the heart like this. All right, let us take step by step. The first thing about the inspiration. It's an example for the short breath film, such like this. And this is the full breath film. As you see, this is the same patient. The problem in the short breath film, when the patient is expiratory, we are maybe to be diagnosed that the heart is enlarged with the wrong manner. It's not enlarged. The problem is the patient is not taking deep breath. The patient must take deep breath, and this is judged by the 8th rib posterior, rib number 8 posterior. When the copula is near this rib, the patient is expiratory. The patient didn't take the deep breath or the deep inspiration. While when the copula is below the rib number 10 posteriorly, this is a full breath film. This is the first step to judge if this film is taken in a good position. For example, in the forms of the job, the application of the something, it's when some patient or someone coming here to do medical check for a job. Sometimes the patient is expiratory. So we may say that this heart is enlarged, or the heart is not enlarged, but the problem that the patient is not taking deep breath. So the first step of evaluation is the patient should have the deep breath of the film. This is number one. Number two, the film is hard or soft. When I say this film is hard and this film is soft, when the film is like this, the spine is prominently seen behind the heart, this film is hard. What is the problem? This hard film may masking a small nodule, a small pathology to be masked within the hard film. And the reverse is the film is soft like this. The film all is white, as you see. This is a low factored film. The technician used low kilovolt or low milliampere, so the film appears to be like soft like this. So also I may see anatomical structure and doubt this is a pathology, but it is normal. So the film must be normal like this. Just the spine is seen behind the heart. Not hard like this or soft like this. Every one of them can mask a pathology for me. All right. Yeah.
Plus, not hard or not soft. I
Yes.
can understand.
To judge the film is good quality, the spine is just seen behind the heart like this, Dr. Anna.
Behind.
Yes, the spine is behind the heart, as you see, all right? If the spine is prominent like this and the both lungs are black like this film is hard.
Black.
Yes, black. There is more factors used, more kilovolt, more milliamperes, all right? While if the film is soft white like this, as you see, I can see the spine here. Anyone can see the spine here? It is not seen, all right? The mouse is not, it is appear for me, not appear on the screen. Yeah. I don't know why really, but the mouse is appearing for me here, not appear on the screen. All right. The upper film, as you see, we can see the spine prominently and both lungs are burned, are black. This is a hard film. While in the lower one, the film is mostly white. Yes, this mouse. All right? You can explain, understand?
Understand.
All right. For steps of evaluation, how I take a steps for evaluation of chest X-ray? The first thing, I am judging the cardiothoracic ratio. We'll see it. The second, the cardiac contour and configuration. Number three, pulmonary vasculature. Number four, pulmonary fields and bony thorax, and finally, soft tissue shadows. Also, the costophrenic angle is the most important thing. Let us see. This is example for the basic chest X-ray finding in one film to remember it. For example, here, as you see in the upper part, this is the pneumothorax. All right, the pneumothorax is abnormal air within the pleura. We will see it in the details. Below it, surgical clips. Surgical clips is an indicator that this patient have an operation. For example, below it, the lung mass, and on the other side, lung nodule. What is the difference? This is the lung nodule. This is the lung mass. What's the difference? Any well-defined pathology below 3 centimeters, I named it as nodule. Any pathology of well-defined more than 3 centimeters, I numerized it as lung mass. Both has its differential diagnosis and not important for me in the emergency, but this is as enumerization. All right, below it, for example, this is atelectasis. This is an example of lung collapse. This is example of hilar adenopathy. This is example for the costophrenic angle obliteration of pleural effusion. This is just as a key for enumerization of the different pathologies. But let us see it one by one. Every pathology in the radiology in general has its chart. For example, if you are judging of a cavitary lesion, for example, if it contains air, is different. It contains air fluid level, different. If it contains a soft tissue, and so on. This is not the key or the aim of our lecture today, but to enumerate for you the system for us as the radiologist when are diagnosing certain case. But for us, what is important? These are examples for the finding. These examples for multiple lung masses, for example, all right. And this is example for lung nodules, example for hydropneumothorax, example for pleural effusion, example for body inhalation, and so on. It's just as a keys. Let us see the emergency finding one by one. The first one, what's your opinion? What is your diagnosis for such like this case? Yes, that's good. This is foreign body, all right. Maybe ingestion, maybe inhalation, all right, we'll see it in the upper part of the thorax. It is foreign body, rounded, mostly coin. It is metallic in nature. It is metal, mostly coin. In such like patient, we do many things. The first thing, we are mostly doing lateral position to see it, whether it is anterior, inhaled, or it is in the upper part of the GIT, for example. The most important information to know about the ingestion or inhalation of foreign body, any foreign body inhalation must be follow up all over the system from mouth to anus, from the beginning, from the mouth to the end of the GIT. Why? In my practice few years ago, a child came for me, he was inhaled a coil. He was suffering from coughing, suffering from bouts of suffocation and so on. Few days later, they came and said the baby became very good. It's mostly that the coin is swallowed and passed in the stool. We do for him abdominal X-ray. When we do abdominal X-ray, we found nothing. There is no foreign body. So the technician tell me, yes, it's good. The foreign body is passed away. I asked him to repeat it in upper level than the previous level to show us the neck of the child. And the surprise was when we repeat the X-ray on the neck, the coin is moved up, not down. It was lodged in the upper part of the GIT. The boy tried to vomit, and the coin moved up, become above the level of the larynx. If we ignore it, maybe at any time, if this boy just changes position, it may be suffocate and die. So we must keep in mind that the foreign body is not only moving down, it may be moving up. Understand me? For example, you may do X-ray abdomen and found a foreign body in the stomach. Okay? When doing next follow-up, we must do it upper than level and lower level because it may be moved up, not only down. It may be disappear from the stomach, but he tried to vomit, the foreign body move up, not move down. So any foreign body follow-up must be done all over the system from the beginning to the end. Clear? Right. This is a sequence of foreign body inhalation. When foreign body inhalation occurs, the sequence may be one of, it may be work as a valve. When the patient doing inspiration, it is moved and make air enter. But when we do expiration, it is lodged and obstruct the airway. Or it may be lodged like this, lodged and completely close the airway. This will be the sequence. Either to make hyperinflation of the segment or of the lung as a whole, right? Emphysema, emphysematic change of the lung, or it may be make atelectasis or collapse of the segment, right? So the foreign body may be do this or this. If it's working as a valve, it may increase the air entry and prevent the expiration. Or if it's lodged and completely close the airway will be absorbed from a segment of the lung and atelectasis will be occurred. All right, what's your diagnosis for this? Diagnosis? This is chest X-ray? No. And we are speaking about emergency only today, not detailed. All right, let us show you the key of the diagnosis. This is the key. What's your bin vascular marking here? The vascular marking here is clear, yes? Wait, I'm here. On the right side, the vascular marking is clear, yes? It's reaching to the lateral side of the chest, yes? On the left side, the lateral aspect, is there any vascular marking? No. There is jet black translucency, yes? Let us see. This is a pneumothorax. The key of pneumothorax is two things. The first thing is absence of vascular marking at the periphery of the lung. And the second is the line of demarcation of the outer line of the lung. Let us demarcate and see what is the pathology where. All right. Look. You can see here, there is no vascular marking. The line here is the line of demarcation of the lung, while in the other side, the vascular marking are faintly seen in the periphery of the lung. This is the key of diagnosis of the pneumothorax. Let us see other case. What's your opinion? It is here more clear, I think. Here, look, you can see this is the border of the lung. This is the jet black translucency. The vascular marking here is visible, while here there is no any vascular marking. So the key of diagnosis of pneumothorax is the outer demarcation of the lung, as you see, and the absence of the vascular marking replaced by jet black lucency. We call it like this, jet black lucency. It's more translucent. Let us demarcate also, you see? So this is an example of right pneumothorax. All right, another case. What's your opinion? I think it is more clear. This is the great difference in between the jet black lucency here and the normal lung here. This is the vascular marking is visualized on the left side. On in the right side here, as you see, there is a jet black lucency. This is not only pneumothorax, this is a right tension pneumothorax. There is a large amount of air that is compressing the lung, as you see, it makes lung collapse. Let us demarcate. This is the lung collapsed, and this is the jet black lucency, large amount of air. This is emergency for chest X-ray, and the patient must have intercostal tube in such like situation. All right, let us see our case. In the last week, in the last Friday, what is this? The previous, you remember the case that presented here. He was a free diver and have a sudden chest pain and so on. He was 33 years, male, heavy smoker, free diving injury, and sudden chest pain. The key, it was diagnosed by Dr. Bilal by chance. This was the diagnosis. In this side, as you see, I try to move the mouse on the screen. Yes. If we see here, this is the line of demarcation of the lung. It is very faint. I can't deny that it's very faint. And outside it, there is jet black lucency. As you see, it is demarcated, such like this. This was the pneumothorax of this side. When zooms appear, yes, this is the lung, you can see. And this is the jet black lucency of the pneumothorax. Let us demarcate, right? Clear? Yes. Then we do follow up. The first follow up, it begin to decrease. The amount of air in the on the left side begin to decrease, as you see. Yes, that's it. And then the decision was to introduce an intercostal tube. Dr. Omar introduced the intercostal tube, as you see, and there was no any pneumothorax. It is disappeared completely. There is no air outside the lung. All right, such like patient must have CT. Why? It is important to know what is the cause of pneumothorax. It's important to know what is the fate of this patient. It may be increased, and the CT, of course, will give us more details than just X-ray. This is the appearance of pneumothorax in the CT, as you see. This is the normal lung. This is the left lung is normal, and the right lung is here collapsed. This patient is in tension pneumothorax, of course. At all, this jet black lucency is the air inside the pleural cavity. What's your opinion? The first question, the pathology is left or right? Right, that's, yes, okay, good, that's right. It is on the right side, that's good. This is the first one. The second, what's your opinion? Is it pneumothorax or not? All right, let us see that the pneumothorax is on the outer surface of the lung, yes? So it takes the same shape of the lung curvature. It takes the same shape of the lung curvature. While this is really, it can be differentiated as pneumothorax, but really this is a large ball. This is large lung ball, as you see. It is not taking the same curvature of the lung. No, it is rounded. It has outer side, as you see. But even if you diagnose it as a pneumothorax or tension pneumothorax, this will be not a fault or wrong. This will be good thinking. But I just enumerate for you that there is deficient diagnosis that may misleading me for diagnosis of tension pneumothorax. This patient, of course, if he has a CT, the Ebola will be appear as a rounded cavitary lesion of thin wall and no content. All right. As the air may accumulated in the pleural cavity, it may also accumulated in the pericardial cavity, such like this. This occurs in many situations, such like trauma. There is a syndrome called Boerhaave syndrome. The patient may have chronic vigorous vomiting and injury of the esophagus occurred. So the air is leaked to the pericardium. So this air is, for example, is air in the pericardium named pneumopericardium. This is another situation of emergency for us in chest X-ray. What's your opinion? Of course, the arrows are pointing on the pathology as we see. What's your opinion about this? What's your initial diagnosis? Don't worry, everyone can say. Dr. Aish, what's your opinion? This is not pneumothorax, yes? Good, that's good. All right, it's rib fracture. Any colleague will want to add another information? It is a single or multiple rib fracture? Yes, that's right. It's multiple rib fracture, as you see. How we judge the rib fracture? That's right. As Dr. Ash said, this fracture of ribs. To judge the rib fracture, let's demarcate. This is the first fractured rib, not the first rib, the highest one, and this is the other fractured rib, as you see, right? This is another example of multiple fractured rib, as you see. The multiple fractured rib in many sites like this, we name it as flare segment. The flare segment is dangerous. Why? The flare segment is interfere with the inspiration. If the rib is fractured in a single location, all right, the patient will have a pain, but he can breathe. But if the rib is fractured in more than a point and many ribs are fractured, there will be a loose segment. This segment is more paradoxical than the inspiration. The patient is inspired, this is go in. So it's interfere with the inspiration, so it's an emergency. All right, how we can judge? If you have a CT, the best for diagnosis is the multi-slice CT, reformat image as you see, 3D CT. It is easy to see the fracture segment and the multiple rib fractures such like this. This all is a flail large segment. It's important to be interfered surgically and fix it. So it's an important situation and emergency. But as regarding chest X-ray, how can I count it? Such like this. To count the rib, we must know that why. How to do it from the posterior of the rib like this. We are beginning posterior from the first rib. This is the first rib. We begin like this. This is the first rib posterior, and I count and by it. This is first. All right, where is the second? This is the second. All right, where is the third? There is the third. All right. So when a segment is fractured here, I can't know this rib is which one fractured unless I am counting them from the first one and go down until I reach this. This is first, this is second, this is third, this is the fourth, for example. All right, this is the fifth, this is the sixth. If I look at it for the first time and didn't count, I don't know which rib is fractured. But when I'm counting the ribs from the posterior of the first rib and go forward, I can judge that this is which rib is fractured. All right? This is the method how we can count the ribs. Begin from the posterior, such like this, sorry, and go forward. This is what first, second, third. Begin from the posterior and go anterior until I count my ribs. All right? All right. Is it clear or anything missed? Koramo clear? It's clear? Yes, or something not clear? All right. Another type of emergency for us or a situation in chest X-ray is the pleural effusion. The pleural effusion is a fluid accumulated in the pleural cavity. All right. The pleural cavity is begin to be filled from its peripheral, the periphery of it, and upward. You can imagine if we have a cup of water, and contains a balloon. All right. When the balloon is sunk inside the cup, the borders of the water will take the curvature of the balloon. That's right. And the same is here. The lung is like a balloon, is inserted in a cup of water. So if we imagine this upper border is like the upper border of the water inside the balloon. So when we are describing it in our report as a radiologist, we say that there is homogeneous opacity obliterating the lower part of the lung with rising upper border to the axilla. This is characteristic of effusion. For example, if the effusion is large amount like this, as you see, homogeneous opacity with the upper border rising to the axilla. This is an effusion on the left side. We may don't explain that the image of any image of X-ray as if the patient is facing me. The left side of the patient on my right hand and the right hand of the patient is on my left hand. All right. When the effusion is small amount, it's just obliterating the costophryngea angle like this. This is a clear costophryngea angle, it's sharp angle. This contains no effusion, while if it contains small amount of effusion, it's just obliteration of the costophrenic angle. For your information, the chest X-ray can't detect effusion if it's less than 300 millimeter. 300 millimeter and less, not seen in chest X-ray. You can see in the ultrasound, not in the X-ray. But more than 300 millimeter, it will be appear a small amount like this. Liters, large amount, it will be appear like this, a large amount. This contains about 3 or more than 2 or 3 liters of effusion, for example. While if it's, for example, 300, 400, such like this, it's just obliterating the costophrenic angle. All right? The effusion also may be accumulated in another site, in the pericardium, in the heart. So it will give me this appearance. This appearance is called a flask-shaped heart. The heart is, in the upper part is narrow and wide base. It is not only cardiomegaly, but it has the same shape of the flask. So we call it as flask-shaped heart. This is characteristic for pericardial effusion. It can be confirmed with the echocardiography or even the ultrasound itself. It can see the pericardial effusion. All right. This is about the emergencies of the chest X-ray as enumeration as the common pathologies that you are seeing. There is another emergency you can see. For example, what should be neurodiagnosis for this? Yes, this is abdomen X-ray, plain abdomen X-ray. Of course, the patient must be in erect position. When we are doing X-ray abdomen for patient expecting intestinal obstruction, the patient must be in stand position, erect position. Why? Because the fluid is go down and the air go up. This makes the fluid level, air fluid level. Air fluid levels more than 3, I diagnose multiple air fluid level and diagnose as intestinal obstruction. If the patient is lying down, the air will be above the water. How can I see the level? I must see it from side. So the patient must be in erect position. All right, as you see, that's right. Intestinal obstruction, there is more than 3 air fluid level, not fluid level, air fluid level. What's your diagnosis? What's your opinion such like? This is the pathology. That's it. What's your opinion? This is the left copy of diaphragm, and this is the gastric bubble of the stomach. And this, what's your opinion? All right, that's right. It is a pneumoperitoneum, whatever the cause. It is pneumoperitoneum, air under diaphragm. The air here is accumulated as a crescent under the diaphragm. This is the right copy of diaphragm. And this is the air crescent under the copy of diaphragm. This is a sign of pneumoperitoneum. Pneumoperitoneum may be due to perforation. For example, this is the most famous cause, GIT perforation. After operation, any patient have a abdominal operation, the peritoneum is open, it will contain air like this for about 2 weeks after operation. So if I do X-ray for the patient after operation and found air like this is not an emergency sign because the peritoneum already opened in the operation. All right. So this is, as you diagnosed, that's right, Dr. Olofa. This is a pneumoperitoneum, and whatever the cause, clinical to correlate. Maybe pervert viscous. This is the first, of course. If there is a peritonitis of a gas-forming organism, it will do the same sign. But of course, it will be more vigorous. Severe peritonitis, severe abdominal pain, rigidity, and the clinical picture will be more vigorous than the perforated viscous. For us, for me as a radiologist, it's important the clinical, for example. This patient may present for me with this X-ray, and I diagnose one of them to be normal, and one of them to be perforated viscous, and one of them to be peritonitis. The first one normal if this patient have operation from 1 week ago. This patient will be normal. It's normal to find air inside the peritoneum after operation. And this patient, if he has a history of peptic ulcer and coming with sudden abdominal pain and rigidity, but there is a history of ulcer, I will expect this patient has perforated viscous. And I do abdominal ultrasound, and the ultrasound will show there is a collection inside the peritoneal cavity from the perforated viscous. If the patient hadn't any history of ulcer but has a severe rigidity and severe high-grade fever and abdominal pain, we may think in peritonitis and gas-forming organism, for example. So the clinical for me as a radiologist is very important for diagnosis. That patient may be normal and may be an emergency. All right, as you see, it's a pneumoperitoneum and the sign is air under diaphragm. This demarcation of the lesion, as you see. All right. This, for example, the air may be a large amount that may be seen on both sides of the diaphragm. So as you see, it is seen here on the right side under the right cupula, and on the left side here above the gastric bubble also can be seen on both sides. But easily we differentiate it on the right side because the liver is under it. There is no air in the liver. Easy to see it, while here it may be missed as interlaced with the gastric bubble. So mainly you are searching for it on the right side for this cause because the liver on the right side and it can be clearly seen above the liver and below the diaphragm. All right, let us transmit to another important emergency daily we see is the orthopedic trauma or the bone trauma. The fracture in the bone trauma may be so clear such like this. It's a complicated fracture of both tibia and fibula as you see. Anyone can diagnose it. But the problem of diagnosis of fracture when the fracture is small, it's just a fissure fracture. So mainly in the musculoskeletal and joint X-ray, we must do two films at least, two views. Each of them is perpendicular on the other. For example, if I take X-ray for the hand, I take one such like this, AB, and other one is lateral. Each film is perpendicular to the other. Why? The fissure fracture may be in a small part of the cortex. When I see it such like this, it will be facing me. I can't see it. But when I do another view, I can see it. So as a base, any X-ray of the musculoskeletal must at least to be at two views. Each of them is perpendicular on the other. I may do other obliques, more than two, but at least must be two. One AB and one I. Or both are perpendicular on each other. One in this plane and one in this plane. All right? This is the basics for diagnosis. Such like this. This is elbow. This is the AB of the elbow. It will be like this. The fracture may be here, for example. I can see in the anteroposterior film. So when I do, for example, the lateral film, I can see, for example, if there is any fracture on the side that may be facing me in the first film. The fracture also may be like this, may be complicated and clear and I can diagnose easily, but it may be like this, such like this view. I can see fractures, as you see. But if we are doing zoom or magnification, I can see a faint fissure fracture here, as you see. So I must, if we see it in this film, we didn't see it, it is here. But if we searching here, we can find it more clear in the on the lateral position. So for this cause, we take more than one position for this is the fracture here, explained here, and small clear in the lateral position. The key, of course, of diagnosis is the discontinuity of the cortical. This is, in any long bone, there is a cortex and medulla. This is a cortical bone, and this is the medulla. The key of the fracture is discontinuity of this cortex. When I see the cortex is continuous like this, there is no fracture. But if we see here, if you see to the cortex will be discontinuity, faint discontinuity. This discontinuity is the key of diagnosis of the fissure fracture for me. The joints in general is formed of articulation between two bones, all right? There is articular surface. Yes, this is the articular surface. This is we named it in the X-ray joint space. It's not a space. It is a cartilaginous structure. But in the X-ray, we see it as space. So it's described as a space. So it's formed of articulation bone, as you see. Articular surface, it's smooth, of course. Any irregularity here is abnormality. Articular joint or a joint space, it is, of course, there's a distance of the joint space. When it is abolished or it is deleted, there is abnormality. And we must remember that there is a growth plate in the young adult. So many times we may misdiagnose this articular plate as a fracture, as you see. No, the site of growth here is the epiphysis. This is a growth plate. It's normal to see this separation at the periphery of the long bone, as you see here, and here, and here, as you see. On the long bones, this is the growth plate. This in young adult, for example, when the patient is 40 years old, it is unaccepted to find something like this. This anatomical structure in the young, but not in the adult or the old age. Another emergency you can see is the stones. The stones for us is mainly, in the past we was diagnosing it by the BUT. BUT or QUB, it's the same, plain urinary tract, or QUB, kidney, urinary, and kidney, urinary bladder. As you see the problem, the BUT, if it's not well prepared before doing the X-ray, it may, any fecal matter were masking the stone. I can see stone here, for example. But when the patient is doing ultrasound, we found the back pressure. But we may didn't see the stone inside the ureter. The exact diagnosis of it is the CTU. As you see, this is CTU or CTUT. The CT, for example, Dr. Omar tell me that there is no CTUT on the system here, on the list of the system. There is plain abdomen without contrast. All right, the same. The CTU is abdomen without contrast. I didn't give the patient contrast except if indicated in CTU. It's only plain abdomen without contrast. So I can see the stone like this. This is a stone inside the ureter. If you search here, you can see it's faint, small. If we do ultrasound for the patient, we can see the back pressure only, but we can't see the stone itself. So the best for diagnosis is the CTU. So in many situations, you find me right for the patient, this for CTUT. I can see obstruction, but I don't know how many stones. If it's only one stone, I give patient medical treatment at it may bust. But if the ureter contains multiple stones, it's dangerous to give him only medical medication. So this patient may undergo operation to remove the stone. So this is the importance of CT, UT in the diagnosis of emergencies of the urinary system. All right, this is the appearance of the back pressure of the kidney. This is ultrasound, as you see. This is the ultrasound, and this is the pelvic system, the black one. As you may know that the fluids appear black in ultrasound, so this is the kidney, and all this black is the collecting system or the pelvic system obstructed, and this is mild to moderate back pressure. But I can see in the ultrasound, I can see except of the upper part of the ureter and the lower part of the ureter only. I can see the main part of the ureter. So I don't know how many stones are obstructing this patient. This is why we are requesting CTU or CTUT for such like patient. All right. The emergency X-ray more contain many other findings, but thank God we didn't see such like this for here. I think this, for example, is multiple firearm injury for a patient. As you see, this is multiple bullets. This is multiple shot also of firearm injury. So the emergency X-ray is wide, but for us here, this is maybe the most important that we can see every day and we can differentiate. And before anything, I am with you, of course, for consultation at any time. So don't forget, the X-ray is the first step of radiological assessment, all right, but it's not the final step. We have also the ultrasound, you have the CT, even if it's not here, and also you have the radiologist with you. Any consultation at any time, you are with each other. I wish that this was give you a value. Next, inshallah, in the next sessions, we'll speak about the fundamentals of the radiology in general, the modalities, different modalities, the radiology and trauma, the CT scan, when the patient should do, and the basics from MRI. This will be, inshallah, the next session. We'll regulate with Dr. Aisha about the suitable time for the colleagues, inshallah. Thank you for everyone. These links are may be helpful for you. You can searching for more details, more films, more data, and the source of the lecture. And repeat my thanks for your attention and wish that I wasn't a heavy guest with you. All right, thank you. All right, now we can discuss any question. No question is about sign, for example. Yes, so you can ask any questions. Dr. Noah, any question? Please, Dr. Aisha. Nothing. You have good sign or bad sign? Dr. Lufa. Yes. Yeah. Hi. Yeah. All right.
When it shows the fluoride, like concave